Hello, everyone, and welcome to the UCLA Esophageal Center Esophageal Insight Series. Tonight, I'm going to give a lecture on Barrett's esophagus, managing the link between acid reflux and esophageal cancer. And over the next 30 to 40 minutes, I'm just going to go through kind of a high-level review of the current state of practice for Barrett's esophagus, starting a little bit about the pathophysiology between linking acid reflux to esophageal cancer, and then talking about how we identify or screen patients with Barrett's esophagus, and then when it's found during endoscopy, how we inspect it. We'll talk about treatment candidates for endoscopic eradication therapy, go through what those therapies are and how they're currently performed, and then we'll talk about surveillance algorithms for patients who have already had treatment and eradication of their Barrett's esophagus. So as a background, a review for everyone, Barrett's esophagus is characterized by replacement of the normal squamous epithelium by metaplastic columnar epithelium, and it's characterized by goblet cells, the way that's defined here in the Western Hemisphere. So that's what we call intestinal type metaplasia. And so you can see in the picture here, the squamous mucosa is this kind of pale pink color, whereas this, what we call salmon color tissue along the bottom is the Barrett's esophagus. And it's suspected when the squamo-columnar junction, also known as the Z-line, is extended to greater than 1 centimeter proximal to the gastric folds. And that's important because there's often confusion on what to do when the Z-line is irregular and it's not extending that full centimeter. And also it's sometimes difficult to determine whether you're looking at esophageal folds or whether you have flattened out the cardiac folds. So sometimes finding exactly where that gastroesophageal junction or the top of the gastric folds are. But as we'll see, it does matter in terms of kind of how we manage those patients that may just have an irregular Z-line. And then to confirm the suspicion of Barrett's based on the salmon mucosa, we take biopsies and send it to pathologists to confirm the diagnosis. So here's another image of a patient with Barrett's esophagus. I think this was characterized as 2 centimeter circumferential, 3 centimeter maximal. And when we look at it under narrowband imaging and near focus, there was areas in the kind of the proximal end of the segment on the right wall with neovascularity, and on biopsies it confirmed that this patient had high-grade dysplasia. And so when we look at the pathway from reflux to esophageal cancer, I describe it to patients as a series of steps. And so first is chronic reflux likely leading to erosive esophagitis. And we often miss patients at this step because it may have been well in the past or chronic over time, sometimes even silent. But the chronic inflammation leads to this change in the lining of the mucosa, potentially as a defense mechanism. There's several kind of pathologic theories on where these cells come from, but you get the intestinal metaplasia, or what we call non-dysplastic Barrett's. With ongoing injury, perhaps, you take the next step forward, which is Barrett's esophagus with low-grade dysplasia, then onward forward to high-grade dysplasia, and finally adenocarcinoma, or esophageal adenocarcinoma. And so I describe patients that this is the spectrum and that they may lie along one of these spectrums. And frankly, I even use this kind of conversation when I'm talking to patients who have run-of-the-mill GERD as justification for treating it at times. And so that's kind of how the current theory is in the pathogenesis of Barrett's esophagus and eventually adenocarcinoma as it relates to GERD. Now, identifying those patients who have Barrett's esophagus is tough because we know that at least 1% to 2% or more of the US population is estimated to have it. In some cohorts, including at VA and Kaiser, and another group that kind of looked at anyone that had an endoscopy added to their screening colonoscopies, this may actually be an underestimate. But the problem is that right now our screening surrounds patients who have acid reflux or GERD, a gastroesophageal reflux disorder. And Barrett's esophagus can occur in patients with or without GERD symptoms. And it can be in the same rate. So when you take two cohorts, same population, and take patients that had or did not have GERD symptoms, it's been shown that sometimes both can have Barrett's esophagus. And another kind of very striking study out of the Kaiser system showed that the minority of patients that they had diagnosed with esophageal cancer over their study period actually knew they had Barrett's for more than 6 months' time. And so by the time they discovered the Barrett's, it was too late. And most Barrett's esophagus, as I mentioned, is probably undetected because of the imperfect screening. And so while imperfect, we still have to start somewhere. And so the guidelines, which have evolved slowly, partially, have recommended that these patients are the ones to screen. And it's based on odds ratios and risk estimates from both large populations and a variety of smaller cohort studies. So typically the guidelines recommend that screening should occur in men, although it can be considered in women who have multiple risk factors. And they more recently defined the frequency or the length of GERD. So typically 5 years or more of GERD symptoms, either present or in the past, in their lifetime, or frequent, weekly or more symptoms. And then one other risk factor. So patients who are over the age of 50, Caucasians, central adiposity. There's some overlap or mixed kind of feelings about whether it's actually the adiposity or obesity itself, current or past smoking, or a first-degree relative with Barrett's esophagus or esophageal cancer. And this seems to be the strongest of the risk factors. Now, when you're reading some guidelines, sometimes it says men with 2 risk factors, and one of them being the frequent GERD symptoms. So there's different ways to look at this, but generally you can kind of picture the type of patient population we're talking about here. But there's a variety of other screening mechanisms that have been proposed, including transnasal endoscopy, capsule endoscopy. There's what's called endomicroscopy, which is kind of a near field image where you can get subsurface features of the epithelium in real time. They've talked about liquid biopsies or blood tests. There's actually an electronic nose kind of exhaled materials, kind of a breath test type thing, cytosponge, and then a few others that I added to this list, something called Watts 3D, which is wide area transepithelial sampling with 3D computational analysis, which actually is promising, and then a few other kind of sampling type brushes or instruments, and then volumetric laser endomicroscopy, another tool which is trying to be developed with artificial intelligence. So there's a variety of things out there. This chart kind of just gives a little overview of accuracy, convenience, cost, et cetera. But of them, none of them seems to be ready for prime time. Perhaps the closest are these kind of wide field sampling methods like cytosponge and Watts 3D. But for now, the gold standard remains high definition white light endoscopy. And this is the problem. It's the reason that we can't do universal screening, because it's frankly not cost effective and may not be clinically effective to do a universal screening. So I think a big need is to find a wide kind of potentially population-based screening that is less invasive, less costly, and less invasive or troublesome for the patient. Now, once the Barrett's has been discovered, something you'll hear me say over and over again during this talk is that adequate endoscopic inspection is critical. And this is where there's probably a big opportunity for improvement. And so in this patient, for example, this is another narrowband imaging photograph of a nodule look at in near focus. You can get a very good idea of what the subsurface or surface patterns are. I'll go through in a minute the Prague classification for landmarks, which we recommend documenting. As I mentioned before, an irregular Z-line, which is salmon mucosa extending less than 1 centimeter, does not appear to be associated with an increased risk of cancer. And so it's frankly recommended in the latest guidelines not to biopsy an irregular Z-line. We advanced imaging, at least with high definition white light, which I would imagine most centers have at this point, but also including optical chromoendoscopy or dye-based chromoendoscopy, frankly, is recommended. And the optical chromoendoscopies differ based on which brand endoscope manufacturer you have, narrowband imaging, iScan, FICE, or some of the other examples. Once the inspection is done, that's when targeted biopsies of anything visible that you found is what comes next. And then finally, the Seattle biopsy, random biopsy protocol, which we'll go through in a minute. So this is the Prague classification, and it's helpful to document all the landmarks, and it's also helpful to prognosticate in some patients their risk of progression, depending on what their underlying pathology is. So the first thing is to document the diaphragmatic impression, the top of the gastric folds, which define whether there's a hiatal hernia, and that will identify your true position of the gastroesophageal junction. Next is to look at how far the salmon mucosa extends proximally, and that distance is what we call the circumferential extent, where it's a continuous tongue all the way from the GE junction up to where that ends, and that's what we call the C. And then if there are any tongues extending more proximally, we call it M, or maximal extent. And so in this example, C2 M5 is the Prague classification. By convention, at least our institutional practice is if there are additional islands of mucosa that look salmon, that may be Barrett's, we document those separately. So C2 M5 with an island at 3 centimeters above the GEJ is just as descriptive. So we talked about the prague classification. Next comes the actual protocol for obtaining tissue from the Barrett's. And as I mentioned before, inspection comes first. And so it's recommended to use HD white light or high definition white light endoscopy, and then some type of chromoendoscopy. And for the most part, the most practical is to hit the button on your device, so that way you're switching to the optical chromoendoscopy, which such as narrowband imaging. It's recommended to spend at least 1 minute inspecting each centimeter of Barrett's. And that can be tedious because sometimes that means that you're inspecting the Barrett segment longer than the entire endoscopy took. But it's been demonstrated that there's a higher miss rate for rapid withdrawal, similar to kind of what we find in colonoscopy. And so it's important to really spend time looking at it closely with both white light and narrowband imaging, using the near focus if you have it, magnification endoscopy if you have it. And it's also kind of, if you're looking geographically where the high risk lesions might be, the right wall and the proximal segments appear to be the hot zones, particularly for long segment. I recommend, if you haven't used a distal cap, trying it out, not only for upper endoscopy, if you look at Barrett segment, but also it can be helpful in the colon and other parts of the GI tract. But a distal cap can really help splay out some of the folds, either the folds of the cardia or even the esophageal folds, and also can let you get right up against what you might think might be a visible lesion, and can avoid that kind of pink out or the mucosa hitting all the way on your lens, and you lose visualization. I didn't put it on here, but for the sake of simplicity, but what we're looking for is really anything that looks different than the run-of-the-mill Barrett's. And so I think that many endoscopists will see it over time, but we're looking for changes in the pattern of the Barrett's esophagus, neovascularity being one of the subtle changes where the blood vessels are not quite as ordered or regularized. But more obviously and more prominently, we're looking for any nodules. So any raised lesions, something that's not completely flat. And then converse to that, anything that may be depressed or ulcerated, that's really what we're looking for. And these visible lesions should be targeted for biopsy directly and sent themselves in a separate bottle to the pathologist. After that, assuming there are no visible lesions or you've done your targeted biopsies, that's when the Seattle Biopsy Protocol prescribes biopsies every 2 centimeters in 4 quadrants. And it's important, the whole segment. And work from our group, as well as many other centers, show that there's a level of fatigue, especially when you're dealing with 11, 12, 13 centimeter Barrett's. But it's been demonstrated over and over again that not sampling the entire segment it leads to missed dysplasia and potentially even missed early cancer. And typically, by custom, I think most of us will start biopsies at the bottom. But I just mentioned that the hotspot is really the proximal area of the segment in new Barrett. So it's important to complete the whole segment with the biopsies, especially in that proximal area. And then it is recommended to have 2 pathologists review. The guidelines vary on whether they suggest 2 expert GI pathologists, but at least one of them should be a pathologist who has experience, knowledge, expertise in reading GI pathology, including Barrett's esophagus, because there's a very high rate of intra-observer variability in labeling dysplasia, as we'll see in a minute how big of a difference that makes. Now, when we look at the progression rate through this pathway from esophagitis to non-dysplastic Barrett's, low-grade dysplasia, high-grade dysplasia, and adenocarcinoma, it's a little bit difficult to predict what the progression rates are for esophagitis to intestinal metaplasia. It is recommended that patients with severe LA grade B, C, or D erosive esophagitis have a repeat endoscopy after 8 weeks of acid suppression to look for underlying Barrett's. But the true rate of progression is difficult to measure and not really well known with wide estimates. So I didn't even put it here. And similarly, we probably very highly underestimate the number of people out there with Barrett's esophagus. So it's difficult to tell how many of them will eventually proceed to dysplasia. But most estimates put the annual risk at less than 1% and probably even less than 0.1%. This risk may be higher for patients with very long segments, non-dysplastic Barrett's with long segments, but it's still difficult to define. There's kind of limited data on that. However, when we get to the story with low-grade dysplasia progressing to either high-grade dysplasia or adenocarcinoma, the numbers have become a little clearer over time. So in the past, the quoted data was as low as 0.6% or 1%. I remember not too long ago. But It can be as high as 13.6%. So why is there such a big range? Well, it turns out that many of these patients with Barrett's esophagus and low-grade dysplasia, if you had an expert panel of pathologists or kind of a second opinion or even a third opinion review, a significant portion of those patients with low-grade dysplasia were actually downgraded to either non-dysplastic Barrett's, or they called it esophagitis, or there was underlying esophagitis. So if you take away the people who didn't really have low-grade dysplasia, that they were misclassified by pathology read, the rate of progression from low-grade dysplasia to high-grade dysplasia or cancer can be as high as 9 to 13%. And so this right here highlights how important it is to have expert pathologists, if not at your own institution, to have a send out to someone that you trust, can use repeatedly, because classification by the pathologist is critical to having a discussion with your patients on what their risk of progression is. And some studies that were very, very rigorous in classifying the grade of dysplasia are the ones that had the highest rate. So so to summarize, if you're classifying it properly, low-grade dysplasia may be higher risk than we previously believed. And then finally, for Barrett's esophagus with high-grade dysplasia, most studies put it at between 6 to 10%, but some of the more rigorous studies, very rigorous criteria to call high-grade dysplasia, again, with multiple pathologists agreeing, maybe as high as 19%, and this is per year. This is annual rates. A few considerations about screening and surveillance in patients with Barrett's. Again, no biopsies for the irregular Z-line. And if there's erosive esophagitis, this can be very difficult for the pathologist to differentiate from dysplasia. And so the recommendation, again, is that if there is erosive esophagitis, unless you're frankly worried that there's a tumor or cancer there, biopsy should be deferred until the patient can be put on maximal acid suppression and brought back for a repeat endoscopy to evaluate the underlying Barrett segment and do the Seattle protocol inspection and biopsies. For low-grade dysplasia, again, it's important to have a GI pathologist review, because if it is downgraded, this can be treated as non-dysplastic. The rates of progression seem to be low. If it is confirmed, a repeat endoscopy is recommended in 3 to 6 months after PPI therapy or proton pump inhibitor acid suppression, with a plan for resection if any visible lesions are confirmed and or seen. And the reason for this is to confirm the diagnosis of low-grade dysplasia, because this is going to prompt the conversation that you may have with the patient on whether to embark on endoscopic eradication therapy. So once we've kind of classified the patient correctly, non-dysplastic versus low-grade dysplasia or high-grade dysplasia, who do we treat? For non-dysplastic Barrett's, the recommendations are surveillance every 3 to 5 years. And we still do see patients that are probably being over-surveilled. And the reason is that in the 2000s, the guidelines called for much more frequent surveillance. It was potentially even every 1 to 2 years. But for non-dysplastic Barrett's, assuming there was a high-quality exam with optical chromoendoscopy and biopsies, the patient is good for 3 to 5 years. I didn't mention it here for simplicity, but for patients that are indefinite for dysplasia, they are in that same pathway of the low-grade dysplasia with the possibility of esophagitis. So proton pump inhibitor, repeat the endoscopy with biopsies to see if they truly are, if they truly have dysplasia or if they are non-dysplastic. If low-grade dysplasia is confirmed on that second endoscopy, or if there's no doubt on the first endoscopy, there are times where we'll embark on the eradication protocol right away. That it's been shown in kind of the major studies out of New England Journal of Medicine, JAMA, the treatment reduced the risk of progression to high-grade dysplasia or cancer by 25% for high-grade and 7.5% to cancer. And so this, combined with that annual rate of progression that I showed you on the previous slide, have been justification to suggest treatment for low-grade dysplasia. However, the guidelines do give the option of doing surveillance, so surveillance in 1 year. And so really it's a shared decision between you and the patient on whether to embark on endoscopic eradication therapy, which, as you'll see in a minute, is no small matter. It can be costly. And so while surveillance may be appropriate, it should at least be considered, and it's a shared decision because of this data that suggests the risk reduction. High-grade dysplasia, I think it's pretty clear that it should be treated. And also early esophageal adenocarcinoma, either in situ or T1A, meaning it has not involved the submucosa, are also candidates for endoscopic eradication therapy or endoscopic treatment. This guideline from 2018 kind of summarizes the current algorithm. So this may be the single most important slide if you're deciding what to do. So if there's neoplasia in the form of any type of dysplasia or cancer, expert pathology review kind of confirms that. A repeat endoscopy after maximal acid suppression to take esophagitis off the table with a close inspection. If there are any visible lesions in that endoscopy, you should be prepared to resect it. If not, biopsy, if you don't have access to kind of the resection materials that we'll talk about. But really, it's to verify the diagnosis. And then based on the above, whatever the highest grade of histology was kind of established from these prior endoscopies, triages them to treatment. So as we mentioned before on the right, low-grade dysplasia, it's a risk-benefit discussion with your patient, shared decision. So surveillance, I think in this guideline, they said 6 months times 1 year, and then annually thereafter, or to embark on endoscopic eradication. For high-grade dysplasia or intramucosal cancer, meaning no submucosal invasion, endoscopic eradication therapy is recommended. And then for most T1B, surgical referral for esophagectomy is recommended, although because of the growing popularity and availability of endoscopic submucosal dissection and some data to suggest that very superficial T1B cancers that are limited to the first third layer of the submucosa may be candidates for endoscopic submucosal dissection. And so endoscopic eradication therapy may be appropriate for some select T1Bs. And it may also be appropriate for patients who are not candidates for surgery because of their comorbidities or after consultation with a thoracic surgeon. Now, before we get into endoscopic eradication therapy, I'll just discuss some key considerations. So number one, again, I will mention inspection is absolutely critical because it will dictate what kind of treatment you give to any one segment of the Barrett's. So high definition white light, some type of optical chromoendoscopy, and consider a use of a cap. Endoscopic ultrasound is of relatively limited value in T-staging for early cancers. And really, the primary goal is to look for local adenopathy. And the reason is that at least the most popular commercially available endoscopic ultrasounds may not get the level of detail to differentiate a T1A from a T1B lesion. And so it's probably better reserved for the lesions that we already believe may have kind of been more advanced. Although there are patients where you're maybe considering something like endoscopic submucosal dissection or piecemeal endoscopic mucosal resection, other endoscopic therapies, where you just want to take the adenopathy off the table. So this is a little bit controversial, probably its own discussion itself. But for now, the value in at least in non-cancerous Barrett's, so Barrett's with dysplasia, and even early cancers is somewhat limited. One of the key principles of the endoscopic eradication therapy protocol is that you're not just going after the areas of dysplasia, you're eliminating the entire BE segment because there's a not inconsiderable risk of it coming back if anything's left behind. Control of pH and reflux is critical to achieving and maintaining eradication. And so towards the end, I'll mention that there are some patients that will actually send for some type of anti-reflux procedure, such as a fundoplication, and then we'll bring them back to complete their eradication therapy. This is a two-way commitment, both on the provider and on the patient, as I'll show you in a minute. And there are quality metrics that are out there, certain thresholds of standards that are recommended in order to perform this, in order to get the best outcomes. And so typically these are centers that have a high enough volume, providers that some have said even 10 cases a year is probably enough, but you need to have access and availability to some of the various resources that we'll get into. Now, as I mentioned, it's a two-way commitment. So this is a typical protocol, including the one that we usually follow at UCLA. We try to meet these patients in clinic to have a discussion about pretty much everything I just mentioned, and to show them that this really is a commitment, the why. There may be potential side effects, pain, et cetera, from the treatment. There may be, while safe, there are adverse events. And so it's important that they understand why they're committing to this. And so typically within a month or so, we'll bring them in to do the endoscopic mucosal resection or an ablative therapy, RFA, which we'll talk about. Typically every 8 to 12 weeks, we'll continue. And the data has shown that in the presence of good acid suppression, good PPI therapy, that it takes an average of 2 to 3 sessions to eradicate Barrett's segments. After they're eradicated, and this is on average 2 to 3, it could be longer, we'll then bring them back for biopsy. So visual inspection shows there's no more Barrett's. we'll do a biopsy protocol. Some centers, in fact, will do another round of biopsies and then say that the Barrett's has been completely eradicated. And then finally, we'll embark on surveillances. And the surveillance mechanism or surveillance interval depends on the initial histology, whether it was cancer, high-grade dysplasia, or low-grade dysplasia. So you're talking about at least 6 to 8 months just in the treatment plus the surveillances. So it is a partnership, and your patients need to be aware of this before embarking on it. And so typically, at least one clinic visit, a minimum of 3 endoscopic procedures, plus the surveillance afterwards. And it's not a one and done. And we make this very clear to our patients before we get started. Now, kind of a quick overview of the endoscopic eradication therapies before we dive a little bit closer into a couple of them. They're the resection, the resective techniques. The most commonly used is endoscopic mucosal resection, but also endoscopic submucosal dissection, more kind of increasingly available. And then we have ablative therapies, and there could be thermal ablation with radiofrequency ablation, hybrid APC, which refers to a submucosal injection of saline followed by ablation, and you can get kind of a deeper burn because you have that cushion. Cryoablation, which is using cold liquid nitrogen, that when it expands, it cools. And then there is a nitrogen-based balloon where it contains a nitrogen inside, kind of a radial balloon, and sprays around, which there's submitted some recent data that we reviewed on this as well. But however, probably the ones that have the most ample data are endoscopic mucosal resection and radiofrequency ablation for both safety and for complete eradication for intestinal metaplasia and dysplasia. So those are the ones I'm going to focus on for the purposes of this talk. Now, when we talk about endoscopic mucosal resection, there are kind of 2 methods that have been popularized for Barrett's esophagus. One is cap-assisted EMR, which refers to a technique where the mucosa is suctioned up into the cap, usually after a submucosal injection, and then there's a snare that's pre-mounted on the outside of the cap, and it could be closed right over what's been sucked up. There's a variety of cap shapes and sizes. It's technically more difficult. The preloaded snare, need to learn how to use it. There's a higher risk of perforation because you can get the entire thin wall sucked in, so an injection is recommended before doing this. Our favorite approach, and what seems to be faster and potentially easier, is what's called band ligation assisted or multi-band mucosectomy. And simple, familiar, it's essentially the same motion you would make to band esophageal varices, and injection is optional because it's very difficult to suck the muscularis propria into the band. It's rapid. You could overlap it to create a confluent defect. And so here's an example in the picture here where just, I think 2 bands were fired and you get a very large defect. And it's safer. The risk of perforation in non-malignant or non-fibrotic kind of lesions may be near 0 in many studies. And then there is a small rate of bleeding, but probably no more than any other endoscopic mucosal resection. And it's important, and especially for visible lesions, not only are we eradicating whatever the nodular or visible lesion is, but we're actually getting a histologic diagnosis from it. And you're getting kind of a larger chunk than a regular biopsy. And it's been shown that the EMR may actually change the diagnosis, either upstage or downstage, what was originally believed to be present in up to 45% of patients. The sample is smaller. However, it can be done in piecemeal, as we'll see in a second. So here's a video demonstrating. So this is band-assisted endoscopic mucosal resection. You could see the cap with the rubber bands pretty much looks exactly the same as a variceal banding cap. Here at kind of the distal end, just above the or proximal to the GE junction and a hiatal hernia was a nodular lesion that was previously identified. And then essentially, it's just combining the techniques of dropping a rubber band and then performing a hot snare polypectomy. So the nodule is sucked up into the rubber band or into the cap. The rubber band is deployed. And now we've got kind of this mushroom. We advance the snare, and then the goal is to actually put the snare between the rubber band and the wall of the esophagus. So it goes under the band, away from the specimen. And that it's safe, and it also will ensure that you get a larger specimen. Now, typically our practice here is to actually use some of the coagulation settings just to avoid kind of oozing and bleeding. But really, coagulation or a mixed type current is probably safe. And then once the lesion is through, particularly if you're worried about a nodule, you can go and grab the specimen right away. Or if it's kind of a larger section, you can just kind of keep going and hit the area just next to it. So here's an example of that. I do recommend for the second and third and kind of fourth bands to take the snare out completely rather than leaving it in the endoscope, because you want that full suction. So if the snare's in there, you might not get as much tissue brought up. And then, as we'll see here, the snare comes back down. And then once the second specimen, again, between the band and the esophageal wall is removed, we'll see kind of a nice large defect, pretty clean and certainly bigger than what would have been done by a hand-based EMR. The patients, we kind of counsel them. They're expected to feel some pain. When we're undergoing endoscopic eradication therapy, either with this or ablation, we put them on twice daily PPI. And I usually recommend it even in the absence of severe symptoms. If they're having persistent symptoms, that's a different story. But and then we also typically send them home with viscous lidocaine solution and then a low-dose liquid narcotic if they need it for backup, and then also some type of anti-nausea medication. And so here's the defect, kind of one nice large confluent defect with just 2 bands. Now, we mentioned that EMR is important for not only the resection, but actually it provides an opportunity for true histologic staging, potentially more accurate than the biopsies. And so the reason that this is important is because the depth of invasion in your specimen is related to the risk of lymph node metastasis. Because at the end of the day, what we really care about is what are the chances that after I do all this work to get rid of this Barrett's with dysplasia or this early cancer, what is the chance that I'm going to leave cancer behind in the patient, either locally or in lymph nodes? And so patients that have high-grade dysplasia, the lymph node metastasis rate is generally reported in most studies to be 0. In patients that have even intramucosal cancer, meaning it is not kind of started involving the muscularis mucosa, the risk of lymph node metastasis is acceptably low at 0 to 2%. And so these are patients that are still considered candidates for endoscopic eradication therapy. Once we have submucosal invasion, typically we do not consider these patients candidates for endoscopic eradication therapy anymore because of an unacceptably high rate of lymph node metastasis. However, with the advent of ESD and endoscopic submucosal dissection, there is emerging data that submucosal cancers, as long as the invasion is confined to the top third of the submucosa, or 500 micrometers, and the pathology of the specimen is favorable, such as well-differentiated, no lymphovascular invasion, et cetera, and potentially performing an EUS to make sure there are no nodes already, there may be select patients, highly select patients, that may be appropriate for ESD and can avoid an esophagectomy. The challenge lies in identifying those patients before we start treating them. And so I think that's one big area for improvement in the future. Now, when to perform EMR. So in general, any focal abnormality that you could see with your eyes should be resected in order to get not only the treatment, but also that histologic stage that we just looked at. So raised lesions, flat lesions, areas of neovascularity, even depressed lesions, you can do a test lift, a submucosal injection, see if it lifts, and then do the band-assisted EMR right after that. So while injection is optional when using band ligation, it can be performed and can help if you're not sure exactly whether the lesion is resectable. Lesions that are less than 20 millimeters that need on-block resection, in general, you want to try to avoid resecting through any type of nodule, so that way you only have one side of a cautery margin and not lateral margins. However, we can do piecemeal resection, and we will in some patients. And early results from kind of the limited randomized control trials do show favorable results of ESD with piecemeal EMR. So some have argued that ESD may not be necessary, but there seem to be fewer adverse events in EMR as well. But as I mentioned, the ESD may have a role in some select kind of early cancers. And as I mentioned, it's extremely difficult to resect the muscularis propria, and the band prevents capture of it. And for this reason, no submucosal injection is typically needed. So we talked about endoscopic mucosal resection. So once we've resected any areas that have visible abnormalities or raised nodularity, et cetera, we then treat the rest of the Barrett segment or any flat Barretts with the ablative therapies. And these are, again, for flat lesions, which are not visible, typically we're going to be talking about radiofrequency ablation, and this comes on the heels now going 11 years strong of a very important New England Journal of Medicine article showing that radiofrequency ablation for Barrett's esophagus with dysplasia was safe and effective. And then multiple other studies have validated this and shown a benefit in dysplasia and cancer and mortality reduction. Now, when we talk about radiofrequency ablation, these are some of the typical catheters we would use. Kind of to summarize one meta-analysis, complete eradication of intestinal metaplasia was achieved in 78% of patients, and complete eradication of dysplasia in 91%. And some more recent studies have been even higher than that. In terms of preventing the progression to cancer, during treatment, only 0.2% of patients progressed to cancer, and then 0.7% of patients after achieving what we call complete eradication of intestinal metaplasia. And compare that to the previous slide where the progression rates were in the presence of surveillance or observation only. The most common adverse event was stricture, typically reported at 3 to 5%. And this video is going to demonstrate the technique that we use. So here again is an inspection of the segment. It's flat Barrett's. This is a size 90 catheter. And it's a focal RFA catheter that's mounted on the outside of the scope. And essentially you want it to kind of be on the top, kind of like a baseball hat. So we think of it like a cap of a baseball hat. You don't want to see the white part of the catheter, so only kind of that hub there. We find the segment. You kind of choose one side to start, line it up, you rotate the big wheel towards you, so you're flexing the catheter hard and typically suck down to get maximum apposition of the mucosa with the kind of the treating element, which is that metal electrode, the copper colored. And then once you've started, you can kind of line up one edge with the other and keep going. I had one endoscopist describe to me, don't stop to admire your work, just line it up, keep going. After we do one set of treatments, either using the tip of this catheter, or in some cases, we'll use a soft cap that's provided by a company, we'll scrape off kind of this white kind of ablated mucosa. And basically we snowplow it into the stomach, clean it up, and then we'll try to hit our own footprint in the same way. And so essentially start at the same spot. And afterwards, you can kind of see that after one treatment, you get kind of this pink color. And then afterwards, you get this tan color, or the chamois color. And that's demonstrated that you've treated both the area twice. And that's what we want to see. Same thing, patients are expected to have some discomfort afterwards, so we prime them for that. High dose PPI twice daily. So I typically do omeprazole 20 milligrams or pantoprazole 40 milligrams. I counsel them every time before and after I see them for the treatment to take it 30 to 60 minutes before meals to get the maximum acid suppression. Because if there's any time to really take it correctly, it's during treatment. Because what we want to grow back after these treatments is normal squamous mucosa and not recurrent Barrett's. Afterwards, so we talked about how this is quite effective, both EMR, RFA. Afterwards, however, there is a risk of post-endoscopic eradication therapy recurrence, post-EET recurrence. So we do need to do surveillance. There's been a couple of meta-analyses, including one from kind of a national consortium that we're a part of, that the recurrence rate may be 9.5% per year of intestinal metaplasia, or another way to say it, 7.5 recurrences per 100 patient years in our study. The dysplasia recurrence may be 2% per year. And there's a lot of controversy over whether this truly represents recurrence or whether it's residual Barrett's or subsurface Barrett's that we didn't treat in the first place. But whether either one is true, whether it's truly recurrence or whether it's residual left behind disease, it just shows that we do need to do surveillance. And so surveillance endoscopies are dictated by whatever the original pathology was. So for high-grade dysplasia, typically it's recommended to do every 3 months for 1 year. And this is with close inspection and biopsies through the segment, and then annually after that. Low-grade dysplasia, 6 months or 12 months, and then in 3 years. And there's been some movement on these timelines, but the point being for the patients that we'll have to have some reasonable, slightly aggressive protocol for following them afterwards, because the rate of recurrence is nearly double digits. Now, if we do identify recurrence, we're prepared to treat them right away. And so we essentially can, if we do see anything that looks like Barrett's, we can do focal ablative therapies with another round of RFA, or resect it if we see anything that's worrisome. Now, some additional work from our group looking at this. Right now, the surveillance biopsy protocol is just, in some ways similar to the Seattle protocol, somewhat tedious. It's 4-quadrant biopsies, depending on which guideline, every 1 to 2 centimeters, including the GE junction. And this is because while the hot zone for non-dysplastic or for original Barrett's may be towards the top, we've shown that the recurrence rates at the GE junction tend to be higher. And so we actually will do biopsies not only of the original segment, whatever that length was, but also the GEJ and slightly into the cardia. I forgot to mention that when we're doing radiofrequency ablation, we do hit a few millimeters into the cardia as well for this reason. So with the current biopsy protocol that's recommended, if you take a 6-centimeter segment of Barrett's, you're talking about 28 random biopsies, in addition to any targeted lesions that you might sample as well. However, we looked at our group's recurrences, 50 recurrences over 10 years, 443 patients who achieved complete eradication. And we found that of the 50 recurrences, only 17 of them were picked up randomly. The rest were actually visible. And so if you do a good close inspection, we hypothesize that you wouldn't need to biopsy so much because you would be targeting the areas of residual recurrence. So when we looked at the data, 98% of recurrences were either within 2 centimeters of the GEJ, kind of anatomically or geographically speaking, or at the site of a visible lesion. So one biopsy protocol that we propose to make life easier for everyone is to do 4 biopsies at each level, starting about 0.5 centimeter below the GEJ, so below the top of the gastric folds into the cardia, at the GEJ, and then at 1 centimeter and 2 centimeters. And so that will reduce the biopsies you have to take by over half while still capturing at least 98% of recurrences. And we're hoping to validate this going forward to, again, make life easier afterwards. Now, finally, this is another kind of algorithm that summarizes the entire pathway. However, there's this side, and we've alluded to it before, but control of reflux is key to successful endoscopic eradication therapy. So if I have a patient who I've already done 1 or 2 rounds of treatment and what keeps growing back is Barrett's and I'm not making progress, or if I have a patient who's on twice daily acid suppressive therapy, omeprazole twice daily or something similar, and they're still having symptoms, I'm worried that the reflux control is inadequate. I also coach them every single time, as I mentioned, on taking the PPIs properly. But if they are still having reflux, we will then, it should be considered to do a pH study. And typically we do a pH impedance study just in case the probe-based catheters are hitting the Barrett segment. And if it's abnormal and they're taking the PPI correctly, there are select patients that will actually send for fundoplication. So such as a surgical fundoplication if they have a large hiatal hernia. We're also growing our transoral incisionless fundoplication program, or TIF, which may be at least efficient enough or effective enough for our purposes, but associated with fewer side effects than surgery. But acid control is paramount. Otherwise, you may fail and may take more than 2 or 3 sessions on average to treat these patients. So kind of that's a very high level overview of the whole algorithm. But when we put it all together, I think these are the most important things. Current screening guidelines and methods are imperfect, but it's what we have. And I think that we're probably under capturing patients as evidenced by those that make it to esophageal adenocarcinoma and we never knew they had Barrett's esophagus. However, once we do identify those patients with Barrett's, careful inspection is critical. To look for those visible lesions, take your time going through the segment, using the narrowband imaging or similar, and resecting anything that's visible, so that way we can accurately stage them and get them triaged to the right therapy. Be mindful of appropriate biopsies. As tedious as it is, once you get into a rhythm, it doesn't add that much time to take those biopsies through the whole segment. And we saw the importance of pathology review to accurately classify the level of neoplasia, if any. Endoscopic eradication therapy, typically EMR RFA is kind of the modern standard of care. It's a 2-way commitment. The low-grade dysplasia is a shared decision, but in general, if a patient is a candidate for therapy, they're in pretty good shape and they're willing to commit, it is probably the favored approach and the recommended approach. And then high-grade dysplasia on T1A cancer without submucosal invasion can be treated endoscopically. And then I think we're staying tuned for what we can do with endoscopic submucosal dissection for those early T1B cancers. And then finally, acid suppression and then surveillance after eradication therapy are important. my predictions and my kind of wish list, if you will, for the future. Where do we go from where we stand now? I think that we are still, our screening is still a little messy. You know, it's not practical to do a population-based screening when we're using upper endoscopy. There's the risk factors, you know, it's difficult to classify the strength of each one of those risk factors, but what we really need is a cost-effective, practical, non-invasive screening test. And there's a lot of people working on this. And I think that it is going to be coming soon so we could start screening more people and then making the endoscopy really more of a diagnostic test. As I mentioned just now, we need to clarify who exactly should we screen. GERD patients with those risk factors, sure. But what about those patients with Barrett's that don't have GERD or had GERD many, many, many years ago and then forgot about it because they're better? So maybe we're not capturing them because we don't even believe they have GERD anymore. So, you know, it's a big problem when we're relying on reflux symptoms to identify who should be screened. I'm expecting and hoping that we can use wide field tissue sampling to replace the random biopsy protocol. I think it will be less tedious, and I think that the random biopsy protocol, it's been shown time and time again that it's prone to sampling error, and I think that we may capture more people this way. And then I also see that artificial intelligence can be used to identify those high-risk lesions and then also guide what kind of treatment you're going to give to the patients afterwards. So there's work being done on this using the volumetric laser endomicroscopy. We're already using 3D computational analysis on the wide field tissue sampling. I think potentially artificial intelligence just during an endoscopy can help identify, hey, yeah, I don't know if you noticed this, but there's a spot right there, neovascularity, there's a nodule, or you know what, this is not high-grade dysplasia, this looks like cancer, and potentially it can also give us a little bit on the depth of invasion of the cancer. So we might be able to be smarter rather than just random biopsies on exactly where something is, targeting it for sampling, and then potentially even guiding us where the therapies are. And I think that even just the next 5 years or so, we're going to see a flurry of kind of improvements and breakthroughs in all of these things. And so with that, I thank you for your time. I'll be happy to take any questions. I'd love to chat with some of you and see where you are. And just want to thank you for listening and for coming to our Esophageal Insight lecture series. Thank you.